Welcome to today's session from ESMO concerning supportive therapies. My name is Alexandra from Korff. I'm a breast cancer patient. I was diagnosed in 2017. I'm at the moment cancer-free, and I'm here today with Dr. Christina Ruhlmann from Denmark, and we will talk about what we have listened to at ESMO and what we thought was very interesting from a patient perspective.
Thank you, Alex. So we really had a hard job, right, to select those studies from ESMO because there was so much interesting news. So we had to decide what to go forward with. So the studies selected are just a sample of the overall production by researchers presented at ESMO this year. So it's a pleasure for me to be here to introduce now the first study, and these are our disclosures. So the first study is the one presented by Ethan Bash from the US, and this is about remote symptom monitoring using electronic patient-reported outcomes. And what is interesting to look at is the background for doing this study is that actually back in 2017, the researchers demonstrated at the big American Cancer Congress, ASCO, results from a similar trial demonstrating an overall survival in patients doing remote symptom monitoring compared to those having just normal follow-up. And this really was a huge eye-opening to all the oncology societies. So we needed to know more what was behind these results. So the US researchers undertook this challenge to do another trial at a larger scale, really to investigate if there is a survival benefit doing remote symptom monitoring. So the reason why they initially thought that this was something to go forward is that during cancer treatment, symptoms are very often undetected by clinicians. Actually, nurses are better at detecting the symptoms than physicians are, but there was a need to really investigate if we could do better. So remote symptom monitoring using electronic, and PRO stands for patient-reported outcomes. If this can detect symptoms earlier and detect or alert clinicians to intervene, thereby relieving symptoms and complications to the treatment. So in all, the study included 1,191 patients with metastatic cancer in 52 US oncology practices. They divided the patients into two groups, and this was done by a method called cluster randomization. This means that one US department took all the patients in usual care, and another department took all the patients in the ePro cohort. So it was not a randomization, just so very random, one patient to one treatment and the other one to the other, but all patients from one institution had to be in usual care or in the ePro. And this is very important in terms of the interpretation of the study results. So usual care, so patients will just address if they have any concerned symptoms, and they will contact the department. Whereas in the ePro arm, patients provided weekly assessments by automated telephone system. This could be by mobile or by computer or telephone. And they did that up to 1 year or until discontinuation of cancer treatment. So every week they reported on 9 different symptoms and what their performance status were and if they had any falls. And then if there was any severe or worsening symptoms as compared to the last weeks, then this generated an alert to the nurses who would then contact the patient to assess if there was a need for for admission to the hospital or if it could be managed at home. And also the symptom reports were available to the clinicians when the patient returned for treatment. The primary outcome, and this is important in terms of the overall assessment of a study, what is the primary outcome, because that's what the study is powered for. So when we look at the statistics, it's always the primary outcome that we have to look after. And so this was the first time they reported the primary outcome, which was survival after 24 months. So they had already actually disclosed some of the secondary outcomes, so emergency department or hospital visits, and patients with benefits in terms of less symptoms in 3 months after study initiation. So now what you might not see very clear from this chart on your left-hand side is there are actually 2 curves and not only 1 curve. So we have 2 very overlying curves. So the one in green is the patients randomized to the electronic patient-reported outcome monitoring, and the blue or purple curve, which is the most evident, are the patients randomized to usual care. So now when you have 2 curves just overlying each other means that it's absolutely no difference between the 2 groups in terms of overall survival benefit. So this is very different from what we saw from the first study. Now looking at other results, so this is the adherence, so the feasibility of such a study. So will patients actually be able to continue doing these weekly assessments? And as you can see, there was a very high completion rate, up to on average 91.5. So this is very good. Some of the other secondary outcomes, and this means not what the study was actually powered to demonstrate, but many times the secondary outcomes are very interesting in terms of safety of a treatment, and in this case, the benefits in terms of better control of symptoms. So the study demonstrated that the patients had a lower number of emergency department and hospital visits compared to the patients having just usual care. And they demonstrated that they had less fatigue, less anorexia, nausea, vomiting, and less sleep disturbances. So those are things that are also important to consider. So in conclusion, remote symptom monitoring with electronic patient-reported outcomes during cancer treatment, it did not impact the survival, but it reduced the visits to the emergency department and hospital, and it had benefits on functions and symptoms. It's also important to mention that a large part of this study actually was conducted during the pandemic, the COVID pandemic, and in that period of time, we had a shortage of nursing staff being provided to the different departments, and this could have an impact on the efficacy of the intervention. And also what I addressed in the beginning of the study was the cluster randomization method, that this can also have an impact on what we see in terms of differences in the treatment arms, because we could have in some of the departments a large cohort of patients from with the demographics making them less likely to actually go to the hospital with symptoms. And if we have more of those patients in the control arm, then this would have really lowered the intervention or not the intervention, the results in that arm. So the method of the study is very important. So what does this mean for everyday treatment? Well, it is actually recommended to use ePro as a systematically assessment during anti-cancer treatment, and Ethan Bass, presenting this study, is one of the co-authors of the ESMO clinical practice guideline actually providing this recommendation. So it is and should be implemented in most departments. So, Alexandra, what are your thoughts about these results?
Well, first of all, thank you very much for presenting those. Well, it's not really breaking news, is it? Because you said that it was already discussed at ASCO. It is, however, interesting to see the impact on side effects. This is my focus, because I, from a patient perspective, I consider that what we see in everyday life, I mean, I'm suffering from fatigue. I know many others who do, and it's also the side effects of vomiting and nausea and anorexia and sleeping disorders. So, and I'm wondering, my first question would be, when you said it's, as you said, it's an issue maybe that they used a cluster as, so it's one hospital that is using the patient-reported outcome, and then one completely different one. So they might have different issues in their institution, and it might not reflect it. However, you said that the device that was used was also telephone calls. Is that right, or did I misunderstand that? So
yeah,
it's not
really. Yes, so so the telephone that they used was an automatic telephone. So when you give a certain answer, then press 2 if you answer this, and then so you have an algorithm in the telephone call taking you to the further steps. So it's not an interaction with the person, but it's an automated telephone call.
Yeah, so we're not talking about apps, but
no.
But an app, would you say, would have the same effect, because it's considering if you report your symptoms, the interaction from the nurses or the doctors could be quicker, and maybe you feel more secure. That I would say, from a patient perspective, if I have something where I enter my side effects constantly, it's not only that I can monitor it, but I feel maybe secure that there's somebody on the other end who also watches the figures, if it's AI or whatever, that alarms somebody if there's something that should be checked up. The other thing, what I found interesting was, do you really think that, because if you're in treatment, there's so many things in your day, in your head, that people really take the priority to report their outcomes if it's not as part of a study? Or how do you, from your everyday life? Because from my point of view, I would say, okay, well, I've tried like apps for fatigue, and then it's like, I don't look at it, and then I forget it for 2 days, and then they remind me, and it gets on my nerves, and it's all too much, and I have no concentration. And I was just wondering, how do you consider that people are really sticking to reporting their side effects?
Yeah, I think that's a very important thing to address, because something is that we use this in a clinical trial, and the other thing is, how do we succeed in implementing in everyday practice? So some interesting results actually that we did not demonstrate here from this study is that the patients were asked if they would like to do this or found it feasible to do this outside a clinical trial, and most patients actually would like to do that. But another interesting thing was that the nurses, 1/4 of the nurses were reluctant to use this as a daily clinical practice, because they did not see that they would have the resources to actually react to the alerts. So one thing so I think we have really to consider how to use this in the most beneficial way, both for the patients, but also for the healthcare professionals. So what is used in many institutions is that you use the ePro before you go to the next treatment. So a couple of days before you have the next chemotherapy or immunotherapy or what it is, then you have to enter your symptoms. And this is mandatory for you to actually be able to receive the treatment. And I find that in our institution, I've this is very feasible from both the patients and the nurses' perspective. And it can reduce the phone calls that the nurses are doing with the patients. So we have a scale going from green to red. So if it's green, it's just a go. And if there's a yellow sign, then there's some observation from the nurse to phone the patient, and if it's red, then there's a need for a consultant with the physician. So I think that we have to really consider how this can be used in everyday practice. So I don't think that it's necessarily weekly reporting, but reporting once before every treatment, that might be sufficient.
Yeah, I think once the results are being shared and you know why you're doing it, that's motivation probably for both sides as well. Thank you.
Yeah. So we'll go to the next study, and this is about cancer patients with immune checkpoint inhibitors receiving also proton pump inhibitor, or to see if it has an impact on the efficacy of the immune checkpoint inhibitors. And this study was presented by Dr. Lawson Ng from the US. And the study was with the title, The Impact of Proton Pump Inhibitor Exposure Before Immune Checkpoint Inhibitors on Overall Survival. And this was a population-based study. So just very briefly, just what is a proton pump inhibitor? So it's not like a real pump, but it's on a microscopic level. In the stomach, we have cell receptors producing different factors that we use to break down the nutrition, to provide some barrier for what we have to the gut and to the blood system. And the proton pump is very important in terms of the production of gastric acid. So the gastric acid, so as the name tells, it's acid. So acidity is very important for us to have the things broken down that we don't want to have further move down to the gastrointestinal tract and to the bloodstream. For instance, unbeneficial bacteria. So those will be eliminated from the gastric fluid because of its acidity. So you know when you have had some retches, heartburn, so the acidity that you feel in your esophagus, or sometimes when you throw up, you feel this acidity. So this is due to the gastric acid. So if we can, so patients really suffering from heartburn and these retches with acidity, many patients with these symptoms will receive a proton pump inhibitor. So this lowers the acidity of the gastric fluid, and hence they will not have the same symptoms. So it's a very widely used treatment in general practice for many patients. So there has been some association between use of proton pump inhibitors and negative impact on the use of immune checkpoint inhibitors. So immune checkpoint inhibitors, those are a kind of cancer treatment that uses a brake on the immune system. So it kind of puts a blood under the brakes in the immune system, so it is more active. So it's widely used, immune checkpoint inhibitors, for both melanoma, non-small cell lung cancer, renal cell cancer, and a lot of other diseases nowadays. So it has really been a breakthrough in cancer treatment. So now we need to see why is it that some patients do not have an efficacy or effect on the cancer from immune checkpoint inhibitors. And it has been raised the question that proton pump inhibitors might be have a negative impact. Because when we break down the natural barrier in the stomach, then the gut microbiome, so the composition of bacteria in the gut, can be changed, and this can alter the response to immune checkpoint inhibitors. It's a bit complicated, but these are the very early signs that we have seen, and some studies have shown a reduced overall survival in those patients receiving proton pump inhibitors, as stated here in one study. Patients receiving proton pump inhibitors only had a survival of 8.5 months compared to those not receiving a proton pump inhibitors having a survival rate of 14.1 months. So this is quite a huge effect if it's really true. So this study had the aim to evaluate the impact on PPI, so proton pump inhibitors, on the overall survival in patients receiving immune checkpoint inhibitors in a larger scale than previously done. So this is a retrospective cohort study. So just as the study we have earlier addressed, so that was a prospective trial. This is a retrospective trial. So patients that we can look up in a large database, so they have received the treatment. So it's not anything about randomization or these very good things to do in a study when we really want to assess what is the impact of this. But this is the next best. So retrospectively looking in a database. So they found patients having an age larger than 65 years receiving immune checkpoint inhibitors, and they found 2,737 patients with a mean age of 73 years. They received different kinds of immune checkpoint inhibitors, nivolumab, pembrolizumab, ipilimumab, and those are two different mechanisms, PD-1 and CTLA-4. Mechanisms that they use, and most patients were lung cancer patients followed by melanoma patients. And what was quite strikingly to see was that 45% of the patients in this database actually received a proton pump inhibitor. So nearly half of patients have at some time point, the 1 year before beginning cancer treatment, they had received a proton pump inhibitor. So as I said earlier, so this is a very widely used treatment in general practice. So, so this is something to look at, really the clear indication for the use of this. So they looked at the impact of the PPI within 1 year and within 60 days prior to starting immunotherapy. And they adjusted for a long list of covariates. So very important in this kind of studies that we see those figures for the adjustments, and this is very, very fair in this trial. So now here you can see Kaplan-Meier plots, as we call them, survival curves. And now if we start on the left-hand side, so this is patients. So you can see two curves, a blue curve and a red curve. And the blue curve represents patients not exposed to PPI, as opposed to the red curve, patients exposed to PPI 1 year before ICI exposure. On the right-hand side, again, the blue curve not exposed to PPI, and the red curve exposed to PPI, but now only 60 days before ICI exposure. What you can see with your eyes only that there is actually the curves are more divided in the 60 days as compared to the 1 year, but this can be just hard to see. But the figures that you see in the table below is that we can see that patients receiving PPI in the 60 days before ICI exposure, they have a much higher risk of survival decrease compared to those just some time before, in 1 year before ICI exposure. So really in the 60 days, there's a huge impact on the efficacy on the immune checkpoint inhibition. So in conclusion, exposure to PPI prior to immune checkpoint inhibitor therapy is associated, and this is an important word, right? Associated with worse overall survival. And we should really look for interventions aimed at altering the gut microbiome, because this may be required to help improve the outcomes of the ICI. This might not be the whole true story about this, because there can be, as I demonstrated, the list of covariates that were adjusted for. There might be others that we just aren't aware of, and those could be at a microscopic level in the gut. But I think this is a very good starting point to start discussing the use of proton pump inhibitors, as you can also see from the chart here demonstrating that in Germany there's a very steep increase in the use of PPI over the years. And this is not just for Germany, this is for the overall Western countries, that there's a huge increase in PPI use. So what does this mean for everyday treatment? Well, I think that all clinicians should review the indication for the use of PPI, because 45% of our patients have been exposed to PPI in the 1 year before starting treatment. So really, it's not the oncology setting we need to address this to, but to the general practitioners, because they really need to thoroughly address the indication for the use of PPI. It's very easy just to make a prescription and say, you can try this for your heartburn, but maybe we should start looking for alternative drugs or measures instead of PPI. So this was quite something about this proton pump inhibitor. Alexandra, what do you think about these results? Do you have any questions, or what are your thoughts?
Well, for me, it was the first time I heard about a proton pump inhibitor. And that's quite interesting, because we're talking about a period in life where people might not even have had received their cancer diagnosis, but they're suffering from heartburn. And this is when they're getting the PPI in order to lower the acid or the reflux. And as a result, maybe a year later, they are undergoing immunotherapy, and it lowers their overall survival by 6 months. That is astonishing. And as you said, the problem is, where do you start? You know, I mean, if you talk to the oncologists, it's not them, if I understand that right, who say, okay, you have an acid problem, and we give you the PPI, but it's rather beforehand. So in theory, yes. And what I found scary is that you say that it's increasing the number of PPIs that are being prescribed. So it's something like, I'm just wondering how these results will affect general practitioners when it was presented at a cancer congress.
Yeah,
just wondering.
Yeah. And really, we have a challenge here to get this out in the public. And again, not to scare patients, because some patients really have the need for the PPI, and we still are in lack of really what is behind these results. So it might not only be the PPI, but it could be other things in the patients that actually triggers these mechanisms. Okay. So what is a hen and what is the egg? So really, we have to find out what's behind this mechanism. But I think there are some indications that we should be cautious about the use of PPI, and look at other measures to reduce the use.
Well, the thing is also what I found interesting, that you said that the PPI lowers the acidity, and the correlation between acid and the overall survival. Interesting. And what I think, however, is when I think from a quality of life point of view, you know, I mean, if you are living with heartburn, it's not a very nice side effect. It's something, you know, you might not be able to sleep, and you have acid, you can't lie down, and you need something to help you with this, because otherwise, yes, you have 6 months more to live, but with the acid. So maybe it's something about, you know, alternatives. You know, what else is there? Is there something else where you say, well, you know, not everybody needs the PPI. There's something else that can be used.
So you're addressing both during cancer treatment. So during cancer treatment, you can receive some cancer drugs and also some adjuvants that can actually make you have this heartburn. And so this is one thing. So during treatment, but the other thing is before even having the diagnosis of a cancer treatment. So I think, so if we look at that large cohort of patients receiving PPI before even having a diagnosis, all those, so in the general community, we have to look at could there be some dietary changes? For many patients, I think obesity is the problem. So obesity and dietary alterations might, for some, because it's just like a quick fix just to have some drug to ameliorate your symptoms. But sometimes you have to go deeper into the conversation with the patient. So we can see that you have a weight excess maybe of 10 kilos. You need to reduce weight. You need to stop drinking alcohol. You need to stop smoking in order to really reduce those reflux symptoms. So I think we have, in general, a really and this is for the general practitioners to take care of, and the community as such. But I think that's quite critical to reduce the use of PPI before the cancer diagnosis.
So you're saying to treat not the symptoms, but the cause.
Exactly.
Okay, thank you.
Yeah. So let's move on to the next study, and this is certainly not about excess weight, but about cachexia. So in our patients who suffer from weight loss due to the cancer. So this study presented by Dr. Korff from Australia with the title Anamorelin and Weight Gain in Patients with Advanced Non-Small Cell Lung Cancer and Cachexia. So the efficacy and safety in the multinational phase 3 scale-up program. So just a little background. So anamorelin is what we call a ghrelin agonist. So it's a drug that can be used to produce weight gain, and it has been marketed in Japan for the indication of cachexia in patients with lung cancer and gastrointestinal malignancies. But it's not used in the Western countries, and now there has been 2 studies performed in Western countries. So those were the 2 SCALA studies. So this was important in terms to have an evaluation in other patients than just the Japanese patients. So these 2 studies, SCALA 1 and 2, are 2 identical trials. In total, they were including 636 patients with advanced non-small cell lung cancer and having cachexia. So cachexia has a definition that was, so we really, and I have to say that for all of the studies presented, that we need to be a bit thorough, not to draw any firm conclusions from these abstracts and presentations that you have seen, but we need to see the full papers when they get published, and then we can go into all the details. So this is just an overview of the studies. So cachexia, in this study, we do not know anything else than they had to have a BMI less than 20 and an unintentional weight loss more than 2% in the previous 6 months. And many times a cachexic patient will have a lower BMI than 20, and they will have a higher weight loss during the last 6 months. So it's about is it the right patients and that are included in the study? We'll have to look more into those details when we have the full publication. But the study divided the patient into 2 groups, so randomized to receive the ghrelin agonist anamorelin for 24 weeks or up to, and the other group received placebo every day. And then they, for the primary endpoint, they assessed the change in body weight over the last 12 weeks. And they also assessed anorexia as assessed by the anorexia cachexia therapy scale, so the FACT scale, and namely the 5-item anorexia symptom subscale 5-ASS. So these are some, from a methodological point of view, important things to address. So we would have liked the study to have addressed some secondary endpoints, and this could be muscle strength. But the efficacy, so the 2 co-primary endpoints, efficacy and in terms of weight gain and change in anorexia score, demonstrated that there was a higher increase in body weight, but there was no increase in anorexia score. So there was no difference in anorexia between the 2 groups. So from the patient's perspective, you could say that having a weight gain of 1.37 kilos, what does that mean if the patient does not feel any change in the way they feel anorexic? So only for the 1 efficacy endpoint, it was there was a positive sign. As for safety, it seemed to be safe. There was a severe hypoglycemia in 2 patients receiving the study drug anamorelin. So in conclusion, anamorelin improves the body weight by 1.3 to 37 kilos over 12 weeks in patients with advanced non-small cell lung cancer and cachexia. It did not improve the anorexic symptoms, and it was really just in consistency with data from other previously studies using ghrelin antagonists. What is, and I would really love to see in the full publication, if there was some impact on muscle strength, improved the lean body mass, because that's quite important for the patients to feel that they actually have a higher level of strength, so they can have a higher quality of daily living, and as such improved quality of life. So for everyday treatment, this is not something that is ready for implementation. It needs to be investigated further, and especially for those things addressed for the muscle strength and improved quality of life. So these are my main limitations of the study. I think that we need to assess really, does the patient have any benefit from receiving a drug? So very important for me. So what about you, Alexandra? What's important for you in this study?
Yeah, well, the thing is if I understand it right, cachexia is you're not only thin, but you're losing a lot of muscle, right? So therefore, if you have something that lets you gain, say, fat and no muscles, could that be still in somehow beneficial? Because, I mean, if you disappear because you have no strength, you're weak, and you constantly lose weight, like you're saying, it's not a good way to gain weight just to gain weight. But I'm thinking, well, instead of completely disappearing, isn't it better to gain a little bit fat than nothing?
Well, that remains to be actually investigated, because we don't know what's overall survival benefit in these patients. And again, if the patients felt that there was an improved quality of life, yes, I would say it was worthwhile. But only gaining muscle mass or fatty tissue could actually be a bad thing in terms of inflammation in the body. So it's not really solved if this has a overall benefit for the patient, because I know what you mean about so they're not totally disappearing, that they actually gain some weight, and that can be a positive thing for the patient and motivational thing for the patient. But if really on an assessment and in quality of life, they don't have that feeling, then there's no idea in giving them some other treatment. And so then we have to look at other measures. And cachexia, we know that inflammation, the systemic inflammation, is really what pushes cachexia. So we need, in terms of having control over cachexia, we need to have control over the cancer treatment, which induces the systemic inflammation. So if we don't have the control over the cancer disease, then we will not succeed in getting control over cachexia. So these are also things that we need to address in such a study, that we need some overall survival data to see if they overall have the benefits.
Yeah, thank you. But I like a lot is that the focus here is on the quality of life, and that they had those questions concerning this. So I like study design. However, from my point of view, I'm thinking, okay, well, nice results. At least we know that it's not the results that could probably help the patients. However, it's good to see that the research is progressing further in this direction.
Fully agree. So let's move on to the next study. So we'll stay in patients with advanced disease and suffering from another severe symptom in our patients, anemia. And the study was with the title Roxadustat for chemotherapy-induced anemia in patients with non-myeloid malignancies, a randomized open-label active control phase 3 study. So just addressing a bit, what is this? A randomized study. So again, we randomize. So it's random. If a patient received either the one or the other treatment. So that's what's behind randomized. Open label means that we know if the patients received the one or the other treatment. And active control means that the one study group will receive a placebo, and the other one the active treatment. And phase 3 means that we will have sufficient enough patients to really have an impact on the study results. So it should be, from this methodology applied, a very high quality study. So chemotherapy-induced anemia. So this is important, that it's just not anemia induced by the advanced disease, but it's chemotherapy-induced anemia that we're talking about here. And it is a common complication of cancer, and it's an important risk factor leading to a poor prognosis for the patients. And we do have the recombinant human erythropoietin alpha, so we call that EPO, and that is a standard of care. But as the authors say, safety concerns remain. In Western countries, we use a lot of blood transfusions instead of using EPO in these cases. But this study was done in China because they do not have the same access to blood components. So Roxadustat is the first hypoxia-inducible factor prolyl hydroxylase inhibitor, and for abbreviation, it's PHI. So we'll just call that Roxadustat. And it is approved for the treatment of anemia in chronic kidney disease, just as EPO is. So in that way, we can say it's a similar drug. And the study here evaluates the efficacy and the safety. So this is also what is behind a phase 3 study, evaluating both efficacy and safety of the drug for anemia in patients with non-myeloid malignancies, meaning that these are patients with solid cancer diseases. So the study included 159 patients with solid cancer receiving myelosuppressive chemotherapy, meaning chemotherapy that will induce anemia, thrombocytopenia, and neutropenia. It was conducted in China as an open label, as said before. So this means we know who received the Roxadustat and we know who received the EPO. Non-inferiority, as stated, means that they just wanted to prove that Roxadustat is as good as EPO. So it's not having the aim to prove that it's better than, but just as good as. The thing is that Roxadustat can be provided as an oral agent. So this is better for the patients than having to come to the clinic for subcutaneous or have a home nurse to come and give them the subcutaneous injections of EPO. And they have the same schedule 3 times weekly for 12 weeks. And they assessed the change in hemoglobin concentration, and they looked at adverse events. So for the efficacy, which was the primary endpoint, we can see that there was no statistical significant difference. And this is important in terms of concluding that the drugs are equal in efficacy. So we can see numerically that it seems like Roxadustat has a higher increase in hemoglobin to 7.1 grams per liter, as opposed to EPO was 15.4 grams per liter. But from a statistical point of view, there's no difference between the two. And the curves you can see with the orange curve, it is EPO, and Roxadustat, which is a blue one, and they are overlying and crossing each other. So really, there's no difference. So in terms of adverse events, so how well are these drugs tolerated? So it's important to look at adverse events as deemed induced by the drug investigated, and not only adverse events from the chemotherapies and things, so but only assessing what is drug related. So if you look at the row called drug related, and maybe I can point, I can see my arrow, drug related AE, so line number 4, grade 3, you can see that for Roxadustat the percentage is 2.5, whereas for EPO, the percentage is 2.7. So there's no difference in severe adverse events induced by either drugs. And in terms of deaths, so the AE number you see here, 11.1 for Roxadustat and 2.7 for EPO. So that's not the drugs leading to death, but it's just the deaths in the two groups for other adverse events. So it could be due to the cancer disease, it could be due to chemotherapy, but not induced by the drug. In terms of deep venous thrombosis, DVT, or pulmonary embolism, PE, so you can see what is set in bold in the bottom row. You can see that, and why is that actually like that highlighted? Because when we increase the level of hemoglobin, then we might have the risk of having it so high that we actually will induce thrombosis. So having the blood not so fluently going through the veins, producing embolism. And there's no statistically significant difference between the two drugs. As you can see, there were 2 patients in the Roxadustat arm and 1 patient in the EPO arm. And in the background population of a cancer cohort, we will see these incidences with a DBT and PE. So this does not provide any safety concern in this study. So in conclusion, oral Roxadustat was non-inferior, so it's as good as subcutaneous EPO. And the efficacy and safety profile, I think because this was not a large study, so it needs to be addressed in a larger study. And also we need to have some more information about the patients included, what kind of diseases and what were the performance status, and how did they do in terms of survival from the different diseases. So we need much larger study to really know anything for the everyday treatment, what it means to everyday treatment. So it's not ready for implementation. And also it's very important to address that when we treat anemia, we need to have a proper indication, and it should follow the guidelines. And this study included patients seeing from just the presentation that we got. Again, we need to see the full publication, but from the presentation, the guidelines were not followed, so patients could be included if they just had a hemoglobin 10 or lower without symptoms. And following the guidelines, they should have symptoms if the hemoglobin is between 8 and 10, then they should have symptoms before we will correct the anemia. And it's important not to correct it too much, so too high hemoglobin can be at risk for the patients. So further investigation are needed. So how did you assess these results, Alexandra?
Well, I find it very interesting because it's always good to have an alternative that is easier to combine with your everyday life. You know, if you just have to take an oral pill instead of going to, they said 3 times a week to go to see a nurse, that's a lot. You know, I mean, this completely is not manageable with an everyday life. So therefore, having an oral option would be great. However, I see your concern that it wasn't a lot of patients, and yeah, there's further studies needed, yes, but at least it's maybe a hope that there will be an alternative than visiting the nurse so many times. So there's something maybe on the horizon, but I understand your concerns that you say, well, if you look at it, you have to have the right frame and maybe more patients as well to make sure that the results are valid, and it's not only done to prove, look, what we have is just as good as what you do already. You know, that's how it came across a little bit to me. But yeah, from a quality of life point of view, it gives hope, I'd say, hopefully.
And yes, and another thing that is important to address in such a study is the patients included. So we know from other studies that using EPO in the curative setting of patients, it can have an adverse effect of overall survival. So we will only use EPO for correction of anemia with advanced disease, where we know we can only give treatment in the palliative setting, but not in the curative setting. So this is an important thing also to address when we see the full publication, which patients were included. Yeah. So
interesting. Thank you.
Great. So we move on to the last presentation. So supportive therapies, cancer patients receiving immunogenic chemotherapy. And this needs a bit of an introduction, because what is immunogenic chemotherapy? So most chemotherapeutic regimens are in some way immunogenic. And in this study, olanzapine for the prevention of chemotherapy-induced nausea and vomiting in patients receiving moderately immunogenic chemotherapy regimens, used, as said, moderately immunogenic chemotherapeutics. And this means that if we did not have those that we actually do have nowadays, very good prophylactic antiemetic treatments, then around 30 to 90% of the patients would actually vomit. But nowadays we have very both efficacious and safety antiemetic regimens to provide to our patients so that they can actually endure the chemotherapy without severe nausea and vomiting. But we know that still, even though we have these very good prophylactic regimens, some of our patients suffer especially from nausea. Olanzapine is it's an antipsychotic actually that is very good at controlling nausea. So this study in moderately immunogenic chemotherapy addressed patients receiving antiemetic prophylaxis, I think I'll just go to the next one, so to see what they did. So they divided the patients into two groups. So again, it's a randomized study, and it included 560 patients receiving moderately immunogenic chemotherapy. And as you could appreciate here is that they have included patients receiving oxaliplatin and carboplatin, and those are in the higher level in the very broad category of moderately immunogenic chemotherapy in terms of the risk of having nausea and vomiting. Irinotecan is a bit lower in the category. And already in our guidelines, the antiemetic guidelines, oxaliplatin and carboplatin has the option of having a high-level prophylaxis. So what they used here was an antiemetic prophylaxis. You can see the standard arm on your right hand, dexamethasone, which is a corticosteroid, a prepitant, which is an NK1 receptor antagonist, and palonosetron, which is a 5-HT3 receptor antagonist. And this is the best antiemetic regimen we can have if we don't actually add on olanzapine. And we could add on olanzapine if we use high immunogenic chemotherapy. So now we're talking about moderately immunogenic chemotherapy. So here, again, they want to improve the prophylaxis by adding olanzapine to the standard antiemetic prophylaxis. The primary endpoint is the complete response rate. And complete response, now when we're talking about nausea and vomiting, it is the proportion of patients with no vomiting and no significant nausea. That means no nausea or only mild nausea. And very importantly, they also assess the quality of life, and that's important in every clinical trial using a randomized setting. We need to address the overall effect on the patients. So for the results, so the complete response, and this is for the overall period, means the 120 hours after receiving chemotherapy, so the first 5 days. You can see for the standard group, there's 86.2% having complete response, meaning no vomiting, no nausea or only mild nausea, as opposed to those in addition receiving olanzapine. They had a percentage of 92.3% with complete response. So a higher percentage, so 6% higher with the addition of olanzapine. If we look at the next two rows, so those address nausea and vomiting, I will just focus on the no nausea row. So you can see there is an increase of around 8% by adding olanzapine. So really the nausea thing is the one that drives the response here, and not that much the vomiting events. You can also see that rescue medications were used by 11.5% in the standard arm, as opposed to only 4% in the olanzapine arm. And that means that rescue medication is very often something that the patients takes to ameliorate nausea in the delayed phase. So not that much vomiting, but nausea. So again, this is a surrogate marker for addressing the need for better nausea control in these patients. There was not any significant toxicities due to olanzapine, and the quality of life was good in both, or as good as in the olanzapine arm as compared to the standard arm. So in conclusion, olanzapine improved the complete response rate by 6%. And yeah, so those were untreated patients. So just a very nice setup of patients. And I will say that olanzapine, as the most important thing, improves the delayed nausea. So what does this mean for everyday treatment? Well, it will have no impact on the clinical practice guidelines. And actually, just these days, we will have the endorsement of new anti-emetic guidelines. So I cannot really disclose that at this time point. But just to say that if a study will have an impact on the guidelines, then we need to have an improvement of 10% or more in terms of having a clinical practice implication. However, I would say that olanzapine is highly effective in mitigating nausea, and that is also why you will see in the new guidelines just a bit. So just to relieve a bit from the reveal a bit from the new guidelines. So you will see that olanzapine will come in more as not just an add-on, but as a prophylactic measure. But still, it is good to use as a PN. What do you call it? You know, the rescue medication. So so as rescue medication, it's also a very good drug. So olanzapine, you should not be afraid of using it. You could use it at the dosage of 5 or 10 milligram. Only use 5 milligram if you are afraid of sedation, or and you can use it at bedtime. It's a very good option for reducing nausea. So, Alexandra, was there any news in this study for you?
Yes. I think it is, even though you say, well, it has to be 10% in order for the guidelines to be changed. I'm thinking, no, like every person who increases quality of life and has less nausea with no side effects from what it reads, or hardly, then I think it's a big improvement on quality of life. And the only question I have is when you say it could be taken as a rescue medication. I remember I had like a bag of, you know, in case you have mild nausea, take this. In case it's a bit more severe, take this. If it's really bad, take this. And if you're vomiting, please call us. You know, there was this emergency plan for when I had my chemotherapy. I did take medication as well on day 1 and 2 and 3. Which helped a lot. But I'm thinking, because this is the olanzapine is supposed to be taken as well regularly, how can it be taken as a rescue medication?
So it can, for those antiemetic prophylactic treatments that do not include olanzapine. So when you will see the new guidelines, you will see that it is introduced actually as a prophylaxis measure, okay, more than just a rescue. But so if it's not used as a prophylactic measure, then you can use it as a rescue medication. Very efficacious. So you can use it if you really suffer a lot from nausea during daytime. You can use it during daytime. But if you really feel, and some people or physicians even prescribe it as low as 2.5 milligrams to breast cancer patients. because those are very often younger women and really suffering a lot from nausea, but are also quite sensible to the sedative effect of the antiepics. Sometimes 2.5 milligrams can do it, but most often 5 milligrams is a good option, and 10 milligrams, in my opinion, this will give some sedative effects. But using it at night time, it will have, well, then you will sleep through it and still have the effect on nausea. And you can use it daily up to several days when you have the nausea. And it's safe to do that.
But probably important to say, you don't just take it, you do consult with your doctor who is doing the treatment. Or,
yes,
you're saying you just like, no, I always think because it's maybe having side effects with other medication, because I mean, there it was only some of the chemos that it was tested with. So it's probably important, you know, to take this information to your doctor and then say, okay, listen, I heard that this could help me with nausea. Can we please implement this in my treatment plan? Is that how it works?
So I know that things work differently from country to country, but every physician prescribing a drug should review the total list of drugs that the patient is taking to see if there's any conflicts between the drugs, so any increase in adverse events by combining drugs. So this is very important. So of course, olanzapine is to be prescribed by the physician, having the responsibility for your cancer treatment, and as such also knows what other drugs are being prescribed to that patient. So this is very important. Yeah.
Yeah, thank you very much. I think it's one of my highlights for this for the studies we presented. What do you think is your highlight when it comes to supportive therapies from this ESMO?
Well, I think that still really my heart beats for all the things that we do around the cancer patients, not only what we can do for improving their survival and hopefully cure the patient from the cancer disease, but really, if we don't provide sufficient supportive care around the patient, and we just decrease the quality of life because of everything that we think we can do to improve the cancer, then we have not done a good enough job. So ESMO and all the studies presented at the track, and we have only selected some of the studies presented at the oral presentations, and there was more than 120 just in supportive care, and I think it was 15 in palliative care and 25 in supportive oncology, which is also a very broad area in terms of what we can do for anxiety, depression, insomnia in our cancer patients. So all this taking care of the patients, there is so much interesting research going on, and some of it at a really preliminary level, and others as full-blown phase 3 trials as demonstrated here. So really, what my heart beats for, to take care of the whole patient and not only the cancer disease, because when it comes down to all, especially when we can't cure the patient, quality of life, and is just what matters for the patient. So if we will provide excellent cancer care, then we need to provide excellent supportive care.
Thank you so much. It makes my heart beat faster, because that is what it's all about. And I see that in more and more research studies and in more clinical trials, the patient has a voice as well. And yes, quality of life seems to more and more become a standard to look at as well, which makes me very happy, and most of the patients as well. So thank you very much for your time, Christina, and I look forward to seeing you the next time. Thank you.
A pleasure, and likewise.